Hello and welcome to my channel. My name is Peter Abraham. I'm a second career registered nurse focused in the area of hospice and palliative care. Those are two separate services. I'm a certified end-of-life doula through the International Doula Life Movement, one of their part-time instructors in charge of continuing education development, as well as the creation of a brand new course, Crucial End-of-Life Conversations, that should be available in early 2026. I'm also the owner of Compassion Crossing LLC in Kentucky. If you're new to this channel, welcome. Thank you so much for taking the time to visit. In this channel, we talk about issues related to death and dying. After all, we are all going to die. Wouldn't it be better if we're prepared? Studies show that if we plan out in advance, and we're not talking suicide, if we plan out in advance how we want to die, we're more likely to have a good death than if we say, we're going to discuss this another day. Or don't bring that up. I got years to live. After all, we don't know when our time comes. Some may live to 105. Others don't even make it into their 50s. Everyone is different. So in this channel, we have videos for my fellow hospice nurses, holistic nurses, end-of-life doulas, for which I am one, and other end-of-life professionals, as well as caregivers and family members. If these are topics that interest you, please consider subscribing, hitting the bell notification below, and hitting the like button, as it does help small channels like mine. The topic for today's video is going to be about morphine, mainly, a little bit about lorazepam, which is also known as Ativan, and some of the other comfort medications at end of life. Before we go into the topic for today's video, I'd like to ask you one question. You don't have to answer in the comments below, but feel free, as this is a non-judgmental channel. But what are you grateful for? What I found out in my 62 years of life is that one of the ways to be able to deal with death and dying and different issues that encircle us and pound upon us is by building up resilience. Resilience is the ability to snap back when tragedy strikes. And tragedy doesn't always have to come in big things. It could be small losses here and there. So to me, there are three pillars. We focus on the gratitude pillar in this channel. What are you grateful for? So for me, in terms of what I'm grateful for, I'm grateful for my wife, Laura. Not only did she put up with me going to nursing school at the age of 50, and my first year, I didn't work. So she was putting in extra hours where she was working so I could just concentrate. I wasn't in school for over 30 years. What would this picture look like? I was literally being vulnerable, was afraid. I wasn't sure whether I would pass or fail or how would I do. I have an associate degree in computer science, but that was 30 years prior, more longer since today. But she put up with all my antics. I am in the autism spectrum, so there's that whole kit and caboodle, so to speak, to deal with in terms of behaviors and sometimes struggling to regulate emotions and so on. And so here we moved to Kentucky late last year, and she suggested, we need to do, we need this back deck that was with the house was a do-it-yourself project from the previous owner. We didn't know how badly it didn't meet code, but she encouraged me, it's a lot of money, but let's spend the money and invest and create a deck. And what a beautiful difference this has made. It's still not 100% complete. They have to do the gutters and the screening. It's going to be a 3 season porch, but wow. So advice for my fellow husbands out there: trust your wives, trust your spouses. You might be surprised of the beauty that comes out of it. So I'm grateful for that. And I'll do my best to remember to include a picture when I edit this video. Now, in terms of moving forward with this topic is primarily for caregivers, family members, and those who have a loved one either considering hospice or already in hospice. It will also be for those who are in nursing school, those considering nursing, those who might be brand new hospice nurses, who are a little bit afraid, may not be willing to use the afraid word, but like you're not comfortable telling a family what morphine to give or calling the doctor to increase the order. So I still remember when I started working for Care Hospice of York, Pennsylvania. I worked for them twice. Once where they were owned by a Golden Living, that was between 2018 and 2020, where I was there for 2 years. I took a small break to work at a local nursing home in between. During COVID, we had close to 100% recovery rate. That's its own long story how we achieved that, but it was achieved close to nationwide. We weren't the only ones. But then I came back when they were under a Medicis and worked for them. I'd have to look back for the period of time. But I still remember when I went to work for them the first time. And here during nursing school, I mentioned that I was grateful for my wife. Well, once I got comfortable with how to study and how to take tests, I started working at a personal care home, Colonial Lodge, out in Denver, Pennsylvania. Yes, there is a Denver in Pennsylvania. Um, and I became close friends, and I'm still friends at the time of this filming with Anita, who is one of the LPNs there, a wonderful individual who is unbelievably skilled. I know I go on some rabbit trails. This is going to be one because there are people out there that they get I'm not sure of the word, whether it's education arrogance or licensure arrogance or certification arrogance. They think if they pile up X, Y, Z, somehow they're better. And it's not that they're not more informed or better educated, uh, but that doesn't necessarily translate to skills. I've had LPNs run circles around me. And granted, there are some I run circles around them. It's not a competition. But Anita was one of those special persons who embodied all of nursing, a loving, compassionate individual, and skilled in so many different areas, including and not limited to dementia care. But I became friends with her, and you know how it goes on social media. Some family members who are close to their loved ones might reach out to you to become a friend. Well, her brother reached out to me and became a friend. And when I went to work for Care Hospice of York, he's saying everybody I know that goes into hospice on the patient side dies. Hello, they're dying. They were dying before they got to hospice. That's why they're on hospice. Hospice doesn't make anybody die. They're eligible for hospice when they have a prognosis. See, a diagnosis is a condition. You have diabetes, that's a condition. You have liver failure, that's a condition. A prognosis is a clinical estimate, keyword is estimate, for how much longer somebody has to live. So hospice is for anyone whose prognosis, again, the clinical estimate of 6 months or less. And I'll put a link in the description below that the prognosis, that calendar, when we say 6 months or less, is not like the traditional calendar of January through December, not a fiscal calendar like May through June. It's its own moving target because it's an estimate of how long somebody may live based on a nurse, an admission. Typically it is a registered nurse. It can't be an LPN. It's either a registered nurse, nurse practitioner. Granted, doctors give prognoses too, but in my experience, nurses because we're front line do better, but they're on hospice because they're dying. Now let's continue with the topic of morphine and the comfort meds. So, and part of the reason, by the way, that this topic came up is there's an article that I wrote and published on compassioncrossing.info on Monday, September 8th, 2025. And the title of the article, my short-term memories like a butterfly. When fear prevents care, how death anxiety threatens hospice nurse excellence. And I will be doing a video about that that'll air after this video. But fear is beyond common in the world. It's not just limited to families, loved ones, caregivers, patients. Nurses are human beings too. We get afraid. And I had a fellow, this person, Summer, I love you, Summer, platonically. My cohort 25 classmates probably going to be busting out laughing and poking at me. That's its own rabbit trail. But Summer, commented on my post because I post my articles on my Facebook page, as well as LinkedIn and other sources, and said that she was doing continuous care. She's a hospice nurse, so she's doing continuous care. So there's 4 levels of care with hospice. I know these are going to be rabbit trails, but bear with me, please. It's educational. 4 levels of care with hospice. The most common is routine care. That's where the hospice team, it's an interdisciplinary approach. So you mainly see the nurse, the social worker, the chaplain, but there's a lot, in the CNAs, there's a lot that's behind the scenes. So routine care are those scheduled visits. How frequently depends on the hospice provider. The Medicare has a minimum guideline that I hope everybody excels from the minimum guideline, but the minimum for nursing is 1 skilled nursing visit every literal 14 days. I'm being very specific, 14 days, not 2 weeks. So if you come every second Wednesday, every other Wednesday, it literally has to be every other Wednesday. You can't move it to a Thursday. There's a reset visit, but that would be its own long story. So routine care is your scheduled visits. Continuous care, which is what Summer talked to me about, and I'm going to come back to that in a moment to complete Summer's story. Continuous care, which is rare. Not all hospices, every hospice advertises because it's actually a requirement by Medicare that they be able to provide it, but very few can actually execute it. So it's kind of an oxymoronic thing. You have to be able to provide it, but many hospices advertise it, and then when push comes to shove, oops, we can't because of staffing. Continuous care is where there is a symptom that can't be managed in the current setting. We're not talking family caregiver burnout. We're not talking about an educational issue that can't be overcome. We're talking about that the patient is having pain and the current doses need to be modified very quickly, or different medications tried. And so instead of having the patient suffer, because the idea for hospice, a good death, a good death is removing preventable distress, removing every measure of preventable distress that's possible. So somebody's having pain, and whether it be morphine or hydromorphine, Dilaudid, or whatever medication is being used, it's not working. And they've tried. Well, we've given the maximum dose. We maybe got orders during the visit to give another 5 milligrams, another 10, or whatever the issue is. It's rapidly moving. Well, instead of saying, we'll call the pharmacy, they'll deliver the medication, we'll come back tomorrow, that's literally inhumane. So continuous care, you have a symptom that needs a nurse and potentially other staff members on site, and we're literally staffing the environment. That's one of the few cases where hospice will provide blocks of time. Blocks of time. A nurse has to provide slightly more than 50% of that time. because we're calling the doctor and we're getting new orders, we're calling the pharmacy, and we're on site waiting for pharmacy to deliver, and we're managing and we're documenting. And there's a best practice for that. And I have that best practice on compassioncrossing.info. If I remember, I'll put it in the article below. But please bear with me. Remember, I said my short-term memories like this. I'm recording. That's the primary focus. So we have routine care, continuous care. The moment those symptoms are managed, hey, we found they needed phenergan for nausea and vomiting. We got the dosing and it's working and the patient's comfortable and we stayed long enough to ensure so we're not, oh, they're comfortable, let's get out the door. No, we're staying to make sure that it's working. And once we're sure, then we're out the door. Then it goes back to routine care. Continuous care requires a doctor's order. So by the way, if you're the hospice nurse and you're on the phone and somebody says continuous care, make sure you get a doctor's order, both a verbal and then get it backed up with a signed during IDG. Make sure, if not sooner, make sure you get the paperwork. Okay. Verbals are important, but make sure you get the paperwork. So you have routine care, continuous care. Then there's general inpatient, and this is what hospice agencies that are telling Medicare they could provide continuous care, but then they don't have the staff. And sometimes, even when you do have the staff, it gets to the point where like you can't do it in the home setting because maybe the best answer is IVs. And most hospices, even if they have the staff, don't do IVs in home. So then they do inpatient, general inpatient. And again, until symptoms are managed, and then discharged to a low level of care. And then the fourth is respite, where the loved one goes to a certified, Medicare certified skilled nursing facility that has an open bed. So there's 4 levels of care. So Summer was posting getting back on track with the fear factor. So Summer shared in a comment on my Facebook page. She's doing continuous care. So she's doing continuous care. And there's a nursing student helping out. Not a nursing student for the hospice, nursing student helping out. The nursing student got overwhelmed through the dying process and literally ran out. Now, we're not talking patient abandonment. I'm not litigious. I don't know all the circumstances, but it was a disappointing event. But that's happening worldwide, by the way, more so in America, because fear happens to everyone. And that's why I believe my channel and channels like mine are so critical, because we have to be prepared. We're all going to die. So let me share with you what I shared with Summer, which is the focus of this video, is when I got out of nursing school, I am so blessed in many ways. I've had tragedy in my life. So when I say this, I'm not saying, look at me, I have all these blessings. Because I've had death and tragedy and loss more, and that's its own story. I don't want to go there. But I graduated Harrisburg Area Community College in December of 2016, took my nursing boards January of 2017, passed 75 questions the first time I took the test. But prior to even all of that, I had a job offer from Harrisburg Hospital to work in cardiology on the 7th floor, 7th Main, on if I passed. So I did. So I started there in February of 2017. And once you're there for 6 months, and I can't speak for all hospitals, but Harrisburg Hospital was, you're there 6 months, you can be floated anywhere. And I enjoyed floating. I was one of those weird persons that, because there were nurses, they hate floating. I was like, more for me to learn. Yes, I'm autistic and an introvert, so part of me was scared. I don't like the S word. But also as part of this story, you get harder cases the longer you're there. And sometimes you get harder cases even when you're there in the first 6 months. But what was happening to me is they were giving me more and more hospice patients. Now, hospice in Harrisburg Hospital on the 7th floor was rare. So it wasn't like it was an every day or every week situation, because the 7th floor, that's where they were getting like echocardiograms or cardiothoracic surgery. These were serious events, but they were more, it's like a cardiology med surg floor for my fellow nurses watching. It wasn't a step down unit. So most of the people who would come back after procedures were relatively stable. I did participate in codes. I just did participate in a number of different, like, wow, this is intense. But one of the cases, like before I go too far down the hospice journey with Harrisburg Hospital, I never mind all these different learning experiences. I enjoy them. That's part of me. I consider myself a lifelong learner, but part of my curiosity was going to the charge nurse and my other coworkers. I noticed that I'm the only one getting these. That's okay. I love them, but why me? And they said, Peter, they gave me a compliment. They said, Peter, you're very good with families and you tend to be extremely patient and you don't mind working through all their questions. Now, from my perspective, isn't that what we're all supposed to be? I thought I'm just being average, and I found out that that's not the case, which to me is kind of sad. But but I also know from working with my coworkers, a lot of them wanted to just like, especially new nurses, task, 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 check, check, check. And I'm like, I want the human experience. It's not about me, it's about them. And what do they need? So in this journey, as a registered nurse in the hospital, not yet a hospice nurse, one of the things that helped me overcome the fear of morphine is I had my first morphine drip. So morphine drip is where you have liquid morphine going through IV right into the bloodstream of another person. So the hospice patient, I had morphine drips are high risk. You need 2 nurses to set it up. You need 2 nurses for every modification, 2 nurses for any interaction with the machinery, because it is a pump. It is a machine that goes through the IV. So the doctor's orders. Now, I don't, being blunt, transparent, I never documented the starting dose or the ending dose. What I remember vividly, because it was that impressionable for me, is the doctor's orders were every 30 minutes. I was working second shift, which was 3 p.m. to 11:30 p.m. I had an interesting schedule. It was either day shift, either an 8 or 12, or evening shift, typically an 8. But every half hour, I was supposed to go in and assess. And as long as the respirations were above 24, I had to increase the dose. I did this 16 times. He started off, this patient was in the 50s. The respirations was in the 50s. Normal respirations are 12 to 20. His respirations were in the 50s. So every half hour, the 3 p.m. we set it up, 3:30, 4 o'clock, 4:30, 5 o'clock, all the way up to the 11:30, the end of my shift. 16 increases. At the end of my shift, his respirations went from the mid 50s, so mid 50s were like 54, 55, 56, to the low 40s, 41, 42, 43. 8 hours, 16 increases, respirations lowered by about 10 respirations a minute. I want that to sink in, because when I went to nursing school and we learned about morphine, not for hospice, the part of the issue for nursing school, and I love Harrisburg Area Community College, When it came to discussion on hospice, we had the front of one page that went over the history of how hospice came to the US. Nothing else. We had one paragraph on multi-organ failure. They don't do a lot of death and dying in nursing school. And while I had basic pharmacology and advanced pharmacology, the advanced was through Capella University when I got my bachelor's. We read about morphine more often in OBGYN, where it's being given potentially to a pregnant woman or just shortly after birth. And then we're told, watch the respirations, watch the respirations. You can lower, you could actually shut off the respiratory drive. And you got this fear of morphine being put into you in nursing school. So I went through my 8-hour shift, 16 increases. And by the end of my shift, I am documenting, and the other nurses, there was night shift nurses that started that were working 3 to 3 p.m. to 3 a.m. And there were nurses coming in at 11 to work from 11 to 7, 11:30 to 7. And I probably looked like the doe in the headlights. And they're like, Peter, what's going on? You look like you're out of sorts. And I shared, I'm doing my final documentation. It's like 16 increases. And I went over the different assessments, not, in summary. And they're like, and? As if this was nothing. And I'm like, aren't you concerned? They said, Peter, during night shift, they're probably going to increase it another 16 times. And if he's still with us, we're in day shift, they're going to do another 16 times. The maximum dose for morphine is, whoa, way up there, way up there. And that was like an eye-opening experience. So let's look at home hospice now, because home hospice, you're not doing IV morphine. So home hospice, you're not doing IV morphine. Home hospice, you're doing liquid morphine. Most hospices, and I'm going to give you both volume and dose, because I participated in a number of end-of-life forums that just try to help caregivers and family members, not just by pointing to articles at compassioncrossing.info, but share what may not even be there. I didn't write an entire, like I've been writing books, but like I don't know it all, and sometimes I don't know what to write. So somebody had, um, posted about, oh, they're giving their loved one 0.25 ml of morphine. Well, we do, that's a volume, ml, milliliters, micrograms. I'm sorry, before I go way off base, milliliters, liters, those are volumes, and we won't do liters of morphine, but milliliters. So 0.25 ml, which is 5 milligrams of morphine, is often a starting dose for many hospice providers. When I worked for Care, which I mentioned earlier, both before and after, Golden Living and Emeticis, their starting dose was 5 milligrams. When I worked for Grain Hospice of York, Pennsylvania, their starting dose was 10 milligrams. So those are typical 10 milligrams, which is 0.5 ml. So for every 0.25 ml in volume, typically it's another 5 milligrams. So 0.75 ml would be 15 milligrams. The whole syringe, which is a 1 ml syringe, is 20 milligrams. So if you were to go to pharmacology and you're going to look up what is the maximum toxic dose, when we talk about toxicity, we're not talking about euthanizing or death. We're talking about the toxic starts, the poisoning starts, not the end result. So the maximum toxic daily dose for liquid morphine is 1,600 milligrams. 1,600 milligrams of liquid morphine, maximum toxic dose. Many hospice providers out there, they're doctors, medical directors, certified in end of life, along with certified pharmacologists in end of life, will share with you that literally there's no ceiling for liquid morphine or any of the comfort meds because the goal is comfort. And if it's being properly prescribed and titrated, you're not they're going to die from their disease long before you get to the toxic dose. I mean the maximum dose. So think about it for a moment, 1,600 milligrams. So a typical bottle of morphine is 30 ml, that's volume. And remember I said there's 20 milligrams per single ml. So 20 times 30, 600 milligrams of morphine in a bottle. If somebody were to, I'm not saying do this, one bottle down, 600 milligrams, another bottle down, 1,200 milligrams, another bottle down, 18. So you'd have to do like 3 bottles in 24 hours. And now you're above the toxic dose. And again, many medical doctors that are trained in hospice and many pharmacists that are trained in hospice. So if that's what it's needed for comfort, so here, if you're giving, I had a pancreatic cancer patient getting 40 milligrams, 2 syringes until we had a local pharmacy compound it so that it would be 40 milligrams per 1 ml. They were getting 40 milligrams of morphine every hour, 24 hours a day. It did not lower their respirations, did not kill them. They were still pancreatic cancer. They were still able to have conversation with their wife. 40 milligrams times 24, 960 milligrams of morphine in a 24-hour period of time, under the 1,600. They were having conversations with their wife. They were comfortable because they were getting that much morphine. It didn't kill them. Somebody's on hospice because their disease process, their condition is killing them, not the medications. Not the medications. Morphine is not euthanizing. I have had cases, or I should say, let me backtrack. When I worked for Caregiver Hospice, that was, again, it was the first agency, and I loved the experience. There were things that I didn't like. That's its own story, but I like looking at positive things. And so like Tara Marie, she's now Tara Marie Pandoli. She was Tara Marie Stein when I first met her. Um, one of my mentors, unbelievably good at mentoring. Um, but with the Sarah Care, I got to every type of cancer and heart case. Unbelievable, wonderful learning experiences. But here, one of my colleagues at a Sarah Care had a case. I had York County. I think this was in Dauphin County that covers Harrisburg and some other areas. She had a case where a very young person had neck and throat cancer. And this here, and I don't mean to be grotesque, but we have to be prepared. But this was falling literally off. In one of the visits, the bone just fell in her hand. So this is why, by the way, it's so crucial for hospices to be open to what is legal, which is palliative sedation in all 50 states, VSED, voluntarily stopping eating and drinking, which is legal in all 50 states. And I'm still struggling with medical aid in dying. I'm still struggling. I try to be my best to be transparent in this channel. But this person couldn't take it anymore. While he was living with his mother, she went out grocery shopping. And he ended up the entire bottle of morphine. He took the entire bottle of lorazepam. I'm going to get into lorazepam in a moment. and he may have taken some other meds. Guess what? He didn't die. 600 milligrams of morphine, and I believe it was 30 milligrams of lorazepam. And again, I don't know what, I don't have a memory of the other meds, but his mother came home from grocery shopping. He was in the equivalent of a medical coma because of it. He did palliative sedation for himself, not in the way that we would have done in hospice, which would have been beyond safer. But his mom ended up, because this is another reason why by the way, to do living wills. She ended up calling 911. They came, charcoal and other medical procedures, and he lived, but was actually worse off than if palliative sedation was asked for and properly given. Palliative sedation, by the way, has to be asked for. It has to be asked for. There are people like me that if I see enough distress, I might suggest it, but it is, while legal in all 50 states, uh, I believe it's better to be asked for, because it does, the intent of palliative sedation is to put you purposefully into a medical coma that you never wake up from until after you die. You can't eat and drink. You will die faster because you can't eat and drink, but it's not euthanasia, because euthanasia is you're dead. The intent is to kill. With palliative sedation, the intent is to have you so comfortable that you're not waking up. So this is why we have to have goals of care discussions. This is why living wills that are you don't need an attorney. It's best done unbiased. It's best done by a competently trained end of life doula like myself and others like me. Pam Carter, the International Life Movement, does training in this area. Complete and thorough. It's not just the state document. There's a lot that goes into something that's complete and thorough. But living will. Talk about palliative sedation. Talk about VSED. And again, well, very controversial. And I'm still trying to wrap my head around it for years now. Because to me, it's that hard to wrap my head around, is medical aid in dying. But getting back to the morphine, getting soon into lorazepam, he didn't die from wham, 600 milligrams of morphine, 30 milligrams of Ativan, and whatever else he took, he didn't die. So if the doctors are prescribing and the nurses are saying, please give the morphine, and I'm going to go to lorazepam shortly, but I do want to share one other story. One of the cases I had, it was a sadder case. And I don't even want to mention the geographic area, just say York County in general, because I don't know if the person who was involved in this will see my video and claim something from a HIPAA perspective. Oh, I gave too much information. So I want to be careful in that regard. But I was the primary caregiver for a loved one on hospice for and I don't even want to give the diagnosis, but let's say they were thin as can be. They had multiple pressure injuries on their body. Let me go back. I apologize. They started with one. Towards the very end, they had multiple. I was combining, but the one on their sacral area, their buttocks, was huge, and I do mean about that size. This is not the big fish. I'm trying to be certain it's about that size. And it was literally down to the bone. And the family would do wound care when I wasn't there. We didn't start off with daily visits. We did towards the end. And they would do wound care. When I would come, I would do wound care. This is a type that had to be You'd remove the outer dressing. You'd have to unpack, clean. There's a level of chemical debriding, and then repack. And then there were other times other nurses would substitute if I couldn't be there for whatever reason, would encourage the family, please give the morphine at least 15 minutes, but preferably a half hour to 45 minutes before the dressing change. And call us if she's crying out during the change. And I would get there and I would ask, and there was no lying, I want to be very clear, but it was like, no, we asked her if she's in pain. She shook her head no. And they did the procedure. And her face was beet red. Tears, I'm talking sobbing. And I would come in and then I would ask, are you in pain? And she'd be doing this while she's sobbing. I'm sighing because this is the ethical dilemma. We're taught to believe the patient, but we also have to trust our own observation skills. Her pain was 10 out of 10. Her pain was severe. And I would go, could I please give her the morphine? And yes, it was after the fact, but it was like pulling teeth because they thought like it would speed up the dying process. It doesn't. It doesn't. I still had the last one before the lorazepam. I still remember my lung cancer patient. This goes back to a care. I'm skipping different um, agencies. My lung cancer patient. I took over the case. When I took over the case, she was over on hospice for a little over a year. I came in. She was with me for 9 months. She was on for close to 2 years. And she was doing 20 milligrams, the whole syringe, several times a day, and still able to do light housekeeping for close to 2 years. It wasn't shutting down her organs. It wasn't making her die faster. It wasn't shutting down her respirations. It doesn't euthanize. It helps her to be comfortable. It helps with breathing. It helps reduce coughing. It helps with so many different areas. So now moving on to lorazepam. Which is also known as Ativan. Couple things for my fellow nurses and caregivers. We talk about, remember, I'm going to say maximum toxic dose, and then the disclaimer that a lot of medical doctors, pharmacists that are trained, and I do mean trained, not trained that they have the title pharmacist or doctor, but they're trained in end of life, will say there is no such thing as a maximum dose for any medication that helps with comfort. And I believe they're right. But if you go to the quote, the textbooks, and you look up on, the drug um, sites on the internet where you could look up what the indicated use is, maximum dose, blah, blah, blah. So lorazepam, Ativan, depending on the site you go to, it's either 10 milligrams or 14 milligrams is the maximum toxic dose in a 24-hour period. Most hospice agencies, if it's the liquid form, it will go 0.25 ml, and there's 2 milligrams per ml. Oh my word, 2 milligrams per ml. So 1 milligram would be, oh my word, 1 milligram would be oh my brain dilemma. I'm not even going to look on the calendar. So I'm going to just go from memory. I believe it's 0.25 is 0.5 milligrams, 0.5 is 1 milligram. And I'll leave it at that. Because I'm having a brain moment right now and I don't want to delay the video. And yes, I'm being vulnerable. I have this. Fellow nurses, by the way, this is why when your family's asking you questions, look at your tablet, your laptop, whatever, look it up. Don't go from memory. Because even if you have good memory in certain areas, you don't want to be off by anything. So And granted, I should, pause and do this for the video, but it's live, pre-recorded from a point of view. So here, you've had to have a lot of lorazepam. I do want to give some caution notes. This is to caregivers, family members, nurses. When lorazepam is given, prognosis matters and diagnosis matters. I want to repeat that again. When it comes to lorazepam, diagnosis and prognosis matter. If you're in the last month of life, you're not going to overdo on the lorazepam. I do have to give fine print regardless of any situation. The fine print for any benzodiazepine, for which lorazepam is one. Alprolizam, which is Xanax, is another. There's all different types. Is you could have what's called a paradoxical reaction. And technically you could have this with any medication, but with the benzos it's more common. A paradoxical reaction is they're giving the lorazepam, which is Ativan, to calm down. But you give it to them and they're wired through the roof and they're like bouncing all over the place. And you're going, what happening? If it's making matters worse, paradoxical reaction, call hospice 24/7 immediately. You need a different methodology. But outside of paradoxical response, getting back to the diagnosis and the prognosis. If you have a loved one with any type of dementia, there are 13 known types of dementia for which Alzheimer's is the most prevalent. There's 5 most common types. You have Alzheimer's vascular, frontotemporal, Lewy body, and mixed. So if you have a loved one with dementia and the prognosis is greater than 3 months, and depending on the case, this is case by case. Keeping in mind, I have to give the disclaimer, not giving medical advice. All my videos are educational purposes only. But any benzo for a loved one with any type of dementia, where the prognosis is 3 months or greater, you have the risk of causing greater harm than good. That's just going to be its own video for a different day. But be cautious. Seroquel is a better alternative. Talk to your doctor, and even with Seroquel, 12.5 milligrams bedtime is a better starting dose. But when you're talking the last 2 weeks of life, last month of life, the loved one's transitioning, we're going to come to the landing zone for this video. And I can't stress this enough, what I'm about to say. Discomfort is equal to pain. Discomfort's equal to pain in the last year of life. So if somebody says they're uncomfortable, treat that as they're having pain. I'm putting that out there because part of America is, especially the Stoics, I'm not having pain, I'm just uncomfortable. Last year of life, same difference. Please treat discomfort as pain. Treat uncomfortable as pain. Treat restlessness as pain. Restlessness is suffering. I've had cases where we talked about continuous care earlier. I've had cases where I've done continuous care for restlessness because restlessness is pain. It's a symptom that needs to be managed. And I still remember a family posting in one of the end-of-life groups where their loved one was restless. They were giving the medications as prescribed, but their loved one was still restless, and their hospice agency said, that's normal. Yes, it's normal. However, it needs to be managed and can be managed. It should be managed because they're having the equivalent of pain. They're uncomfortable. It's preventable distress. So in ending, one, morphine is not euthanizing. A person who is on hospice or eligible for hospice is already dying. And we're not trying to make them die faster. We want them to be comfortable, and morphine helps in so many areas. And if it's not morphine, it's Dilaudid, it's fentanyl, it's oxycodone, hydrocodone, it's whatever the doctor is prescribing. It doesn't speed up the dying process. It helps them that when they're comfortable enough, their body's already dying. When they're comfortable enough, they can let go and have a good death. It's not about hanging on to the last minute, crying and sobbing and being in so much discomfort and calling that a good death. And some would, and that's their choice. But for many, that isn't a good death. Many want to die comfortably in their sleep. Well, if you're comfortable, you can sleep. If you're comfortable, you can go and pass. So give the comfort medications. You're not making them die faster. You're honoring their wishes for comfort. And this is the second point. Please, please, please have a thorough and complete living will done for your benefit. Because if it's in writing, if it's properly witnessed, at least to unrelated, not the person helping you fill out the paperwork, and you're the one filling out your own paperwork in blue ink, and properly notarized, is a legal document that anybody who's disobeying your wishes can then be taken to court. And that threat of suit, like I have the paperwork versus hearsay, is powerful. If you have any questions, non-judgmental channel. Platonically love you. Thank you and bye.